Hey everyone. All right, we're back for our final presentation. I'm just going to wait 1 minute because I know that we ended it a bit close to the hour. So, I guess if we could share Dr. Sarah DeSilvey's slides. There we go. Ah, perfect. Excellent. Thanks, Sarah. All right, so I'm just going to introduce Sarah, and just for those of you who may have joined, if you have any questions, you can put them in the Q&A box, or if you're not able to see the Q&A box, feel free to put it in the chat box too, and I'll be checking there as well. So I wanted to welcome Dr. Sarah DeSilvey, who's been working on the Gravity project. And Sarah balances practice as a rural family nurse practitioner with advocacy for addressing the social determinants of health in clinical community practice. Her area focuses developing the terminology to capture the process of caring for patients' social needs. And over the last decade, she's collaborated with colleagues at Children's Health Watch, the Food Research and Action Center, and Siren on medical and social care integration and interoperability projects, such as an overview of food insecurity coding in healthcare settings, existing and emerging opportunities, and the compendium of medical terminology code for social risk factors. Sarah's been working on the Gravity project for, I guess, the last couple of years now, and trying to get national consensus in the US on an initiative to develop terminology to address social needs. And she serves as the director of clinical informatics, helping to weave the practice of social care, community-based approaches, and the literature of social risk into healthcare terminology. So thank you, Sarah. I'll turn it over to you.
Thank you, Marcy. I think, can you all hear me? Wonderful. Yeah. So it is my honor to be here today talking a little bit about what's happening in the US and some international work regarding building data and data standards to address social determinants of health. Just want to thank Dr. Pinto for his presentation prior. I met Dr. Pinto through our colleagues at UCSF Siren, so it's always nice to hear his perspective. So if Dr. Pinto gave the why, so this is some further discussion on how to do this and how to do this well, and how to make sure that what we're documenting and what we're sharing across clinical settings conveys the meaning that we intend to convey. So this is who I am. I am the Director of Clinical Informatics at the Gravity Project. As Marcy mentioned, I am principally a family nurse practitioner in rural primary care just across the border in Vermont. So if you hear noise around, it's because I'm taking time out of clinic to present to you today, as usually is with Gravity, like fitting it in around different things. So I do actually, before I go any further, I saw a mention during Dr. Pinto's conversation regarding links. I tried to drop into the all chat many of the links that I will be referencing in the slides, so they're live and you can capture them. Links to the Gravity webpage, some of our materials into one of the foundational, like my favorite data justice paper that I'll be talking about when we get to our data principles. So I tried to top load those because once I start talking, it's difficult. I don't think I can see the QA and it's hard to access the chat. So hopefully you'll have those live and can follow them after the presentation or during the presentation if you desire. So I'm going to briefly go over the Gravity Project team, the background or why we're doing what we're doing, and if the prior two presentations didn't make the case for why, I'll try to do a little bit extra effort there. I think Dr. Pinto made a pretty good case. I'll discuss the two different work streams. Again, I lead one, I lead the terminology work stream. I'm describe the methods of language making for social determinants of health. And I'll briefly go into the technical work stream, which is led by my colleague, Bob Dieterle. Again, not my area of expertise, but I do my best. I'll address some key questions I want to leave you all with that we have kind of ferreted out in our work at the Gravity Project, and to describe some accomplishments and success factors, and then describe how to engage. I do want to state, of course, that the payer ecosystem and some of the services ecosystems of our two countries are vastly different. So I do apologize for any US-centric discussion that comes up in the presentation. Much of our terminology work is actually international, so I hope it's relevant for the work you're doing in Canada as well. So the team is as follows. So our program and project management all comes through EMI advisors who are well versed in the data standards and policy world. Evelyn Gallego is our program manager. Carrie Lausberg is our project manager. We have policy assistance from my colleague, Mark Savage, who's a policy expert. I lead the clinical informatics workstream, and then my colleague, Bob, as I mentioned, leads the technical workstream. This is a complicated org chart, but it just wants to show you kind of the governance system that is infused in the Gravity project now. So what started out as kind of a conversation between friends, talking with our colleagues at UCSF Siren, has turned into a national, very government embedded initiative with, we have a governance structure with an executive committee. I want to pause and just say, you can see in each of our committees, we have intentional stakeholder representation. And so we have representation from patients and consumers, providers, payers, vendors, community-based organizations, because as we say in Gravity, we might identify problems in clinical settings, but we solve them in communities. And then the federal government. So we have an executive committee, a strategic advisory committee, a technical advisory committee. We have those two work streams, as I mentioned, the terminology and technical work stream. And then we have our collective. So I lead the collective meetings that happen, they're open and free, with about 1,800 members now. About 100 to 200 members every Thursday show up, and we'll talk more about that in a second. But across all of these different committees, again, the U.S. Government is very, very much embedded in our work, both from a data perspective and from a health policy perspective. So this is just a statement on our project grantors and funders and in-kind support. Many hands make labor light, so we only are as strong as our organization. And then now the background. Again, Dr. Pinto and the prior speaker made a very good case. So I just state very basically what we know is the role of social and environmental risks in health and health outcomes are very well known, right? The why we need to address social determinants of health in order to care for patients and populations, that's clear, whether it be from a food insecurity, housing instability, or transportation perspective. They estimate about 80% of a person's wellness comes out of that mix of social, environmental, and behavioral concerns. So why capture social risk data in a standardized and structured way? So as care for social needs has advanced in clinical settings, there's an increasing demand to expand and standardize the terminology to address social needs. And this is in order to better care for patients with social needs in the populations they live within, to collaborate with clinical and community partners, to study social needs, their effect on health outcomes, and the effects of our interventions to address them. And in the U.S. perspective, again, our U.S. frame is to allocate resources toward social risk within value-based care. So the U.S. Healthcare model is largely fee-for-service. So as we try to change this, addressing and documenting patient social risk is critically important to ensure that we're having the right resources flow to the patients that need them. So the Gravity Project came out of a multi-year initiative to basically define the lay of the land for social risk data in U.S. healthcare settings. So there was an initial meeting in 2017 in DC that called national and international experts in social determinants of health to discuss where we were basically. And the assessment was there's a lot of social risk data out there. We don't know how good it is. Again, this is healthcare terminology when I say data. We don't know if it's the correct terminology. And so we need to basically identify what's out there, assess gaps, and then make sure that we fill those gaps based on the evidence. Out of that gathering, I wrote a paper with our colleagues again at UCSF Siren. It's called the Compendium of Medical and Social Needs. You can find that on the UCSF Siren website and then the links below. We found a lot of code. We found lots of screening questions, lots of procedure questions, lots of diagnoses and assessment data, lots of treatment and intervention data, but it wasn't, again, assessed for how good it was, how well it matched the domain at hand. Another reason why the Gravity Project was born was what we know regarding capturing and exchanging social risk data. So when we talk about social data, I'm not just talking about what's in my own system. We're really talking about the complexities of documenting and sharing information, not just with clinical settings, but community-based organizations as well. So there was a paper just recently in August on the challenges in social determinant of health data capture and exchange. And these are challenges of consent, like how to manage consent as data is exchanged, challenges of standardization of social determinants of health data collection and storage, and Dr. Pinto talked at great length regarding standardizing data collection through standardized questions and answers, data sharing, and this is part of what I just discussed, comfort with digital solutions, because if we're going to be talking about sharing information or what we call interoperability, we have to assess various levels of readiness to do the work. Concerns both from a patient perspective and a community-based organization perspective and a policy perspective on sharing that data, really on social care sector capacity and capability. So as the US particularly has moved to address social risks in clinical settings, there is an increased burden on the community-based organizations that have been doing this for a long time. And are we developing the infrastructure to support that work in the community, driven by the community, who will help us solve the problem? That's an ongoing question in the US space, at least. And then there is a pushback on possibly the unnecessary medicalization of social determinants of health, like what is clinically relevant, what is community-based, and how do we make sure that we really are centering the patients and communities in our work, as Dr. Pinto spoke to. So out of all this, the Gravity Project was born. So in May 2019, the Gravity Project was launched as a multi-stakeholder public collaborative. And the goal is to develop, test, and validate and standardized SDOH data for use in patient care, care coordination between health and human service sectors, for population health management, for public health, value-based payment, and clinical research. And this is again a nod to our colleagues at UCF Siren, who were the anchor organization for that initial work starting in 2018, working with our colleagues at EMI, who are now the program and project management team. And it was all started through a grant from the Robert Wood Johnson Foundation. This first link is part of what's in the chat if you want to follow it to the Confluence site. So the goal, again, rephrased, is to develop consensus-driven data standards to support the use and exchange of social determinants of health data within the healthcare sector and between the healthcare sector and other sectors. You can see our roadmap of the domains we're covering is fairly robust. I'll go through some of the domains we've covered so far and our approach and what we've learned in the timeline over the next few slides. So the use cases that ground this work, again, from a terminology and kind of grounding perspective, are as follows. We aim to enable the documentation of social determinants of health data in conjunction with the patient encounter. And this is standardized terminology from our healthcare terminology standards organizations, such as LOINC from Registry, SNOMED CT from SNOMED International, and ICD from the World Health Organization. The next use case is to document and track that social determinants of health related interventions to completion. So if Dr. Pinto in his screening and is identifying a need for a patient, referring to an outside organization to address that need, how do we enable the capacity to get that information back to the clinical setting so they can know the need was met? And then the last one is to gather and aggregate SDOH data for uses beyond the point of care. And again, this is population health management, quality reporting. We're working with our partners to develop social determinants of health specific quality measures, and risk adjustment and risk stratification. So Gravity has convened over 1,800 participants from across the health and human services ecosystem. This includes clinical provider groups, community-based organizations, standard development organizations, federal and state governments, payers and technology vendors. We have a public call that's open to one and all from 4 to 5:30 EST every other Thursday. And you can see the membership of those of the collective at one of the links that I posted in the chat. Again, these are our work streams. So the terminology and technical work stream are intertwined. We work side by side. So as I'm leading the development of the terminology to address social determinants of health, Bob is mirrored and marrying that work in order to enable the technical specifications within an HL7 FHIR, which is a standard developments organization, to share the terminology we're creating through web-based methods that allow for the meaning of what I'm creating and we're creating in the terminology side to be maintained. And we'll talk more about that in a second. But so what we do on the terminology side is we collectively work to develop data sets for each individual domain that represent what needs to be said, and then we analyze those gaps, and then we submit new codes to our standards organizations who are at the table. So almost all of our public meetings, we have representatives from LOINC and from SNOMED CT and from the CDC and ICD-10-CM at the meeting, just watching and making sure we're all speaking the same language. And then eventually we'll publish value sets for these individual domains in our Value Set Authority Center at the National Library of Medicine for the US. I do want to state again, much of the terminology we're building, and you'll see this in the slides ahead, from a programmatic standpoint or an intervention standpoint is US based just because of US programs, but the goals, diagnosis, and even the screening questions and answers are largely international. So this is our roadmap. I know it looks probably a little overwhelming. So where we are right now is represented by the green line. So over the course of the last few years, we've gone domain by domain to address food insecurity, housing instability, homelessness, inadequate housing, financial insecurity, less than a high school education, being a veteran, being unemployed, transportation insecurity, and we just completed material hardship and just completed stress, right? These are all domains as identified by a seminal paper from the US National Academy of Science and Medicine on what domains to focus on first. We will wrap up social isolation, intimate partner violence, and elder abuse from a screening questions and answers and diagnoses perspective by the end of June. Again, all along with this work, my colleague Bob Dieterle is leading the technical work in conjunction, so building that interoperable data standard to enable the exchange of the information. We'll again talk more about that in a bit. So I'm going to speak briefly regarding the terminology workstream, and then again regarding the technical workstream, then have some thoughts and considerations and go from there. So terminology, that's what I lead. So I'm first going to speak to what exactly we mean when we say community data set identification, because this is the heart of what we do. So the community data set identification is a collaborative consensus process that leverages peer-reviewed literature, subject matter expertise, terminology and informatics insight, and the brainstorming of the collective to develop a comprehensive data set for each domain of reference. There's these phases in our work. So we identify and brainstorm together. We collectively sit back and review the data set for completeness. And then we have a consensus vote on that data set. And then we analyze that data set for gaps, as I referenced on the model. And then we build terminology with our data standards organizations to address every gap. And then we test, evaluate, feedback, and the loop goes on. I really think it's important to call to light the evidentiary grounding of that identification process really clearly. So we have a team at Gravity. We have a clinical informatics and process insight. That's largely me, the clinical informatics, and we have a few other clinical informatics reps in the group. We have terminology and taxonomy leadership. We have, for each domain of reference, we gather subject matter experts who are, hold deep evidentiary grounding and content expertise in the domain of reference. And this is both from a measurement perspectives like psychometrics and measurement and screening tools and questions and answers, and health risks and intervention. And then we also have the community. So between all of these, we're always balancing clinical and process insight, terminology and taxonomy insight, the literature and evidence of the domain at hand. We also bring in public health literature to represent risk related to health outcomes, because if we're making decisions regarding terminology, we really want to make sure the health risks and the health concerns that that drive the elevation of that social risk are front of mind. And then the community is a really good practical fit. So the community is just this broad collective. They help us analyze whether things are necessary and not. Again, we imagine this a many year project. So we really want to start with what's necessary and be fairly practical, so the community gives good pushback about that. all the data is sorted across 4 different activities into this master set, as I talked about. So this is a visual that represents that sorting. So we gather and collate standardized and validated screening questions and answers into one part of the data set, basing our approach on some of the US methodology through our census, through our USDA food security module, which is the sister to the Canadian module, through American housing assessment, and through standardized disseminated national screening questions and answer sets. And then those are married and matched to the terminology they're associated with, which is LOINC or registry. We do the same for diagnoses. So we consider the domain of reference, what needs to be said about that domain, what terminology exists for that domain, and then we build collectively into SNOMED CT or ICD-10 CM, which is the US extension of ICD-10. We then do goals, and when we're talking about goal setting, we identify both patient-centered goals from the patient perspective, their own goals for care regarding that social risk. And this is working with our patient advocates and patient representatives, and also goals insofar as quality measures, insofar as treatment goals, I mean, so what a provider goal of care might be. And then lastly, we consider interventions, and I'll talk more about that in a few minutes, but this is all then built into SNOMED CT. What am I doing to address the risk that's identified? Again, so you have a food insecurity identification, what programs, professions, or people am I connecting that patient to once the risk is identified? So we identify all of these concepts that we need to say. We reflect again on what codes are available to represent these critical concepts that we've identified, and then what codes are missing. We do want to just to restate again, so we don't just take this, what is there, what does the evidence say perspective. We also think about our stakeholder perspectives on data. So we're taking on and off the lens from a terminology or clinical perspective, but we're also thinking about perspectives of what is kinds of data does the provider need to take care of their patients, a hospital need to study the effects of provider interventions, a community-based organization need to address the needs of their clients or make the case for reimbursement through revenue sharing, a state need to plan for population health, and what principles do we need to consider to keep patients at the center always. Every time, this is regarding interventions, so we are a terminology organization, so everything has methods. So whenever we identify programs, professions, or people that need to be considered to address a given problem, we wrap all of those programs and professions and people with standard agreed upon interventions that have a common definition. So assistance, coordination, counseling, education, evaluation of eligibility, which is critical for US programs like, food stamps or, Section 8 housing waivers, evaluation assessment, provision, which is when you're directly giving something to somebody, and referral. So all of these terms, you'll see them kind of marry in syntax in a few minutes. And then over the course of time, as I mentioned, once we've identified that data set we need to say, the US works with, the Gravity team works with US and international terminology standards organizations to build all those concepts into code. So all screening questions and answers that we've identified as critical get built into LOINC by working with registry. All diagnoses that we identify as critical, we go 2 different directions, both with ICD-10 CM through the CDC, and through SNOMED CT via the National Library of Medicine. Again, right now, even though we submit to the US, we're doing a lot of our build with diagnoses across international SNOMED CT because of the dearth of social risk concepts in SNOMED CT as it stands. When appropriate in US use, we build across billable terminologies such as CPT and HCPCS, which are US specific. This is an example of what this might look like based on what Gravity has done so far. So food insecurity was our first domain that we covered. It's actually how I came into the project. I came in as a food insecurity expert, and I am an accidental informaticist. So this is what happens, I guess. So if you were thinking about how this might play out within real terminology regarding a real problem, the way this would play out is as follows. So within screening and assessment, All of the US core tools for assessing food insecurity as endorsed by the United States Department of Agriculture are now built into LOINC. That critical 2-item questionnaire, or the hunger vital sign, is built into LOINC as well. I believe that might be the tool that Dr. Pinto is referencing. And so you can ask patients questions, get standard answers, and you're able to share that information and maintain the meaning, because we know exactly what's said because it's retained in the data. And then with diagnoses, we already had, that was one of our first initiatives, we have a food insecurity finding code within SNOMED CT. And you'll see very shortly in the US, we have a very robust expansion of ICD-10 that's coming to address social risks very shortly. Within goal setting, you have the meta goal, which would be food security. And then we broke down sub goals for the subtype experiences of food insecurity, such as number of meals and snacks daily, or quality meals and snacks daily. Again, this is aligned with the domain, because sometimes you need mini goals that are actionable. You might not help the person be fully food insecure because of the heft of their daily experience and the chronicity of the condition, but you can address small things and have small wins. Within interventions, here's some other examples. So you can see all the US programs to address food insecurity are built in, which we call, there's a program called the Child and Adult Food Program. You can see very universal concept is a provision of food voucher. And you can see that we've built a concept for a really critical role within US healthcare to address social determinants of health, and this is the community health worker. I'm unaware if you have a correlate in Canada in healthcare practice, but what we often do in the US is elevate lay people as connectors. So as we identify situations in clinical settings and solve them in the communities, these lay people or connectors are the navigators that help patients get from the identification of the need in the clinical setting to the need being met in the community, and they remain a constant presence for the patient as they go through that process. So we build, again, terminology to represent those professions as well. This is an example, very small, and I did put it in the chat, the ICD-10 CM submission of the robust expansion of terminology. Again, this is only in the US right now, because it is in our US extension, but pending build, we'll be able to specifically document food insecurity, transportation insecurity, housing instability, which is unstably housed but not homeless, which we know is critically important from the healthcare literature, and also financial insecurity and material hardships. So this is all expansion that's going to come over the next year or so within US ICD-10. We are working, I do want to promise everyone, with the World Health Organization to try to get as many of these concepts as possible into ICD-10 11. We know that's a few years out, but we've already learned so much from our work. We're trying to make sure we advocate for the next version of ICD-10 to be able to represent these concerns. Again, this week, Dr. Pinto was talking about COVID, so we want to specifically highlight some of the terminology that's coming, that we've learned to be relevant regarding the COVID use case. So within our diagnostic terminology, we're asking for a differentiation between sheltered homelessness and unsheltered homelessness. This is in order to be representing transitions of care and considerations for non-congregate housing within COVID positive individuals. We do have a concept coming within SNOMED regarding substandard housing due to overcrowding. And again, this is to correctly enable supported housing to enable isolation in the presence of a COVID positive individual. We also have concepts coming for all of the core elements of inadequate housing, whether they be lack of adequate plumbing or presence of contaminants in the household or lack of safety or mold. Those will all be blooming over the course of the next year in international SNOMED as well. And again, specifically interventions you think about within the COVID use case, we have platforms in the US that help make vendors that help make the connection between clinical and community settings. So we enable referrals to that through our terminology. We have specific kind of anti-poverty agencies through US policies, so we're enabling the referral to those. Again, there's that community health worker, which is the critical connector, and then there's a representation of entry into our system that manages applications for housing within the presence of homelessness. So again, all of the interventions are not international. Those would just be kind of plug and play with the Canadian approaches and Canadian programs, unless it's a role, like we can imagine the community health worker being something that might be applicable across international settings. Oh, this last one, it's not bolded, but it's actually really important. We also ask for a specific concept for what is called medical respite. So this is when an individual is homeless and they need to, and they can get admitted to a hospital setting because they have a critical, because they, the homelessness plus the illness warrant the admission that otherwise might not warrant admission status. So this is, it's called medical respite. And it's a really critical finding and intervention within U.S. Within U.S. homelessness health risks and the research that we have there. This is just the Confluence. This is how to access everything that I just mentioned to you. The Confluence is massive. So it's like 2 years of labor representing work streams across terminology, technology, policy. If my contact information, I think, is at the end, and you can always write me an email. Marcy's aware I try to be fairly available. I just might not write back immediately because I do work in clinic. But this is where you can find all of our work, and this is where the community finds the work that we're doing regarding each of our individual domains. You can see each domain has a button. Each button takes you to that data set that we're developing, and you can learn about where we are in that process, whether we have completed the data set and it's in build, whether we've completed it and it's been released. You can see every single data point regarding the data development in the Confluence. Just trying to find my button back, here we go. I did want to spend a moment, again, this references something Dr. Pinto was talking about as well, and I highlighted a paper in the chat. There's a lot of work regarding data justice. The Gravity Project identifies itself as a social justice driven organization. So as we consider addressing what Lynette Taylor, who's the author of the study, of the paper that I put in the chat, which Lynette Taylor calls the injustice of invisibility. So as Gravity builds terminology to define social risks, the risk of being hidden or the injustice of being hidden is addressed. But as we address the injustice of being hidden, you suddenly have the risks of being in the ecosystem. There's so much amazing and really powerful research regarding data justice in ecosystem, whether it be Dr. Ruha Benjamin, Meredith Broussard, Kathy O'Neill. So all of this information is part of what we do at Gravity. And out of that, we created data principles. So the Gravity Project, data use principles for equitable health and social care. And these are the core principles. And again, I did the link in the chat. So all the terminology work we just described, addressing that risk of being invisible and being hidden, elevating these concerns into the healthcare ecosystem. These are the things that we need to keep in mind, right? That the goal is to improve personal health outcomes. The goal is to improve population health equity. We always need to make sure we're ensuring personal control. We have to make sure that we're designing appropriate solutions. And these are all unpacked in the link. We have to make sure that we're ensuring accountability, and in every single thing that we do, we have to aim to prevent, reduce, and remediate harm. So as we do all of our work in Gravity, these are the principles that ground us. And again, they're based on some of the literature regarding data justice and bias and everything from what's not being mentioned, such as the Indigenous or COVID data project in the US, to what happens when you do have data with bias and algorithms and all the concerns that happen therewith. So there's the link in the chat, as I mentioned. I'm going to briefly go into the technical work stream, and then we're going to open it up into Q&A. Again, technical work stream is not my domain, so I'll do my best to pinch hit for Bob. So the Gravity Project is an HL7 FHIR accelerator project. So FHIR, Fast Healthcare Interoperability Resources, is an interoperability standards organization that works to address concerns of providers, health directories, public health research, social determinants of health, that's us, clinical decision support and payers. So you can imagine what happens is as we identify all of our data sets for each of those domains, and we build them into code, and we create these value sets that we are able to reference within our Value Set Authority Center. Those value sets become the anchor of the terminology for exchange of information across settings using HL7 FHIR. So our HL7 implementation guide, again, it's right here in reference, and I don't think I put it in the chat, but I can do so. It's called the Social Determinants of Health Clinical Care FHIR Implementation Guide. It again supports the same activities that the terminology work group is doing, except for a couple more. So again, being able to share information on assessments, on health concerns and problems, on goals, on interventions, including referral tracking, on consent management, and on aggregation. So that if those of you, any of you are familiar with FHIR, the ballot was completed in January 2021, and now we're working on revisions. The use cases for the FHIR implementation guide, again, this is about data exchange. So some of them are the same as terminology and some are not. So it's again about SDRH data in conjunction with patient encounters. They add documenting social determinants of health related goals, so the patient goals of care can be exchanged with patient consent across different settings. Again, it's the same established and related interventions to completion. So documenting and tracking referrals, making sure the interventions are completed. That's part of the technology use case as well. They add documenting and measuring outcomes. This is both to enable quality measures and to make sure that when you identify a goal associated with a problem, you're actually achieving the outcome you intend to achieve. There's that same aggregation of information use case as well. This is all within the IG. And again, managing patient consent. So across every single phase, again, from a social justice perspective, always trying to figure out what information needs to be exchanged, how is patient consent established, every single movement of information across different settings. These next wireframes are really quite complex. It's just to say these are all the pathways of information exchange the implementation guide is attempting to represent. So whether the information originates from a provider in an EHR, from a payer, or from a public health agency, who is the person who is naming the information, whether it be the patient or a legal representative or a caregiver, how are community-based organizations participating in that information, and what kind of technology do we need in order to enable the exchange. I'm going to go more into the technology bit in a second. This is just another version as well. You can see these are the pathways of information exchange that they imagine. And some of this right now is based on program type and what we're learning in the implementation guide and considering data exchange. So we're likely going to move away from considering organization type to really just basing on what can people do, like what functions can a person perform? Because often in the social services sector, if I can't solve your problem in the food bank, I'm going to bump you over to the church down the way, and we're going to keep on trying to drill on the problem to make sure that it's addressed, and it's not as linear as this kind of organization only can do this thing. So this is a work in progress. Now on to some key questions, and then some success stories, and then questions from you. So key questions for us. I really just want to make sure that everything that I presented, which you can find on the Confluence, it probably was fairly overwhelming because what we do is kind of complex. There's some really important terminology and technical considerations that weave through everything that we do. One of the things that we consider is how fit it is to adapt public health social risk tools and definitions to clinical use cases. So as we work on our domains, we're often adapting definitions that were common in public health settings to meet clinical use cases. The example of that is our food insecurity definition that we had to refine really to be person-centered and represent the concerns of the individual. And we did that in collaboration with experts at the World Health Organization and US and the United States Department of Agriculture and food insecurity researchers across the world, just to make sure we got it right. As I mentioned this already, so we consider what happens when you address the injustice of invisibility and need to anticipate address the risk of becoming visible. So this regards like how do we, for that preventing, reducing, and remediating harm concern. Again, on consent, we have very, very vocal and engaged patient advocates throughout our organization that make sure that we're going to get this right. We also are always considering how to represent goals. These include patient goals, provider goals, and patient-reported outcomes. We're always asking ourselves what's necessary. So the minimum viable product, like what do I need to make, what do I need to exchange in order to get my patient taken care of well? And again, this is actually part of that lens of preventing, reducing, and remediating harm. So if I make the package as trim as it needs to be, there's not excessive information going into the ecosystem, the privacy of my patient is as intact as it can be. One of the things we've also identified is a need to establish what we call a taxonomy of programs. So although we have I have a number as an individual, we have a taxonomy for medications, really these critical national program types that we use to address social risks. Without that, we have really clunky what's called syntax, right? I can't just wrap a program with an activity and send it off. Everything has to be basically a sentence, like referral for food stamps or referral to food bank. So we're working on developing that syntax for each of those different program types as well. We also work on trying to consider how the language I use in healthcare settings mirrors the language that's already happening in human services worlds. Like the language that's happening, we're addressing food insecurity in the Canadian government. The language that's happening addressing housing, right? So each of us have developed our own terminologies over the course of time. Healthcare is actually fairly late to the game. So we are always anticipating how to make sure we're in keeping and in kind with what's been present in the social ecosystem before us. And the last thing, and then there's the cascading referral patterns, like if someone's getting bounced around to different agencies in order to get their need met, like how does the referral come back? And then lastly, this is from a social justice perspective as well, we're very careful to anticipate the labor that we're placing on community-based organizations. So we acknowledge, and that was named in an early slide, there's a technology gap. Many of these organizations that are working in communities don't have the robust infrastructure of the healthcare system. So we're considering how to bridge technology gaps and how to support community-based organizations in the labor of doing so. And then this is a slide on how you could incorporate data standards into your work. This is again the work of the HL7 Fire Implementation Guide. So standardized social risk screening, as Dr. Pinto was talking about, adopting standards of data exchange. And then we always want to make sure that we're engaging patients and caregivers in platform design. And then this is just a work in progress, so shared testing infrastructure. So as you do this kind of concurrent social and healthcare setting, initial steps of developing agreement on what we're saying, the idea is to make sure that that you're also agreeing on how to share that information through trust frameworks and making sure that you have this, you're collaboratively working on solving the infrastructure hurdles that come along the way. I think I'm going to stop there so we have time for questions, but this is just from a very US perspective, our final slide. So what the Gravity Project has borne through its work is policy changes through our federal partnerships, which again are very US specific. There's payment and policy, and there's payment changes that are happening through value-based healthcare initiatives. We work directly with programs and other standards organizations. We participate in the development of quality measures across all social risks. So we just completed a TEP on food insecurity, incoming TEPs on transportation insecurity. A TEP is a technical advisory panel or technical expert panel. We're doing panels as well on housing and transportation, again, to ensure that common terminology we're developing is part of those quality measures. And then we have all kinds of federal grants that partner with our work to make sure that there's the funds that are needed in communities to get this work done is present. How to engage? This is us. And I think that that's it, and we can have questions now. I'm sorry, that was quite a fast and full presentation, Marcy.
That's okay. That's great, because I know it's been like 2 years of work. So yeah, it's been amazing. So that's actually my first question is, as you know, we're trying to start something similar in Canada. And so I guess, are there any key yeah, I guess what I've been debating is, do we start with the principles, or do we actually take one domain that you've started on and look at it from a Canadian perspective? Those are just some of the 2 ideas that we've been having, Dr. Adeline Conklin and myself. But what I guess is, what are some key lessons you learned, and where would you start if you don't, we don't even have funds yet, right? So we're trying to figure out how to get this going. So if you have any advice around that.
Oh yeah, we didn't have funds for a year either.
Okay.
Not to bust the bubble, but I was unpaid for the first year. So yeah, but I was able to say it was my doctoral work. That was the buy-in. So I think the thing is that there's a lot that Gravity is leading on that doesn't have to be replicated. So what we would be able to say is there are some things, hopefully, that that the labor can be shared, like collectively agreeing on what we might need to say regarding social risks, like the terms and diagnoses. Hopefully that work, I mean, based on what we're hearing from the international community, is not work that has to be adjusted too much, right? So there was no term for food insecurity. Hopefully we'll change that. Or terms for housing instability, et cetera. Right. So I think what one could imagine doing is assessing what's already ready for go live in the Canadian environment, and then what's specific. And so what we are learning is very national based and setting based. Again, are those programs and interventions. The interventions landscape is very unique. Like, I mean, what even just the term that's used in a Canadian setting for the same type of program will be different. And I think there's just going to be considerations regarding exchange that are much less cumbersome. There's not quite as many players in the Canadian ecosystem as there are in the US ecosystem. I mean, the US healthcare system is just a cacophony of things, right? Yeah. So they're hopefully what you can imagine doing is analyzing what's happening in the US work, and then just you know, assessing what has to be adapted and changed in the work for Canada, but knowing specifically that most of the interventions terminology would have to be recreated in order to be fit for Canadian use.
All right, great, thanks. There's a question coming up about, can you speak about your planned work on the smartphone apps?
Yes, I know I brushed. Okay, so when we talk about, sorry, there was a lot to say. So I'm going to admit I have questions regarding the smartphone app, but this is the problem. So when you're trying to share information across settings that have vast technological resources into settings that do not, right? So, and ensuring that community-based organizations have the support that they need. One of the methods that we're developing in order to, again, enable that, specifically the referral loop, like how do I ensure that the need I identified has been met, is to use APIs and web-based and handheld apps you can have on your phone, right? So the community-based organization would have access to the app, the patient would have access to the app. And so as the patient is able to navigate to the community-based setting in order to get their needs met, they're able to have the information entered into this, again, this API or this app, and it goes right back through FHIR back to the healthcare setting, and then that referral loop is closed. So it's really like one of the only means we can identify right now in the absence of a national social data infrastructure to allow for information exchange into settings that have vast, like, inequities and different levels of capacity of information exchanging. I didn't even talk about pilots, but as we're doing our work in pilots and like in testing some of this, there's 3 strata of pilots we imagine. Like, 1, first, can we agree on what we're saying, right? 2 is, can we anticipate using standards and how and standards of data exchange through any method? And the last one is testing the FHIR implementation guide.
that kind of ties into one of the questions that came up was, how do you conduct a risk assessment of a new standard on the community from which the data is being collected? So are there ways that you actually, yeah, I guess engaging with the community?
So I guess there's so many different kinds of risk.
Yeah.
So I guess I want to understand what kind of risk the questioner has in mind, because there's a very specific answer for every different kind of risk. Because is it the risk of collecting the information? Is it the risk of the social domain itself? Is it the risk of the labor, as I was discussing, for the community-based organization? So if someone can help me understand what kind of risk, I will have a better answer.
Yes, I guess, yeah, the risk of the use of the information once it's collected.
Yeah, so right now, actually, we've just done our best to cross-check with all of the experts that we can, and So one of our data principles in that last one, really preventing, reducing, and remediating harm, is we actually document what could be the potential risks for the different domains that we are working on. Like, for instance, when we were doing the unemployment domain, part of what we do is, in our anticipating risks perspective, is documenting the risk of having this in the exchange with given migrant laborers and some of the rule changes that were going on with U.S. citizenship and Medicaid, our federal low-income healthcare qualifications, right? So, for instance, like, if you do not have a job, you might not get citizenship, and you might not get the U.S. healthcare because the U.S., with our past administration, had a rule that said that you were not worthy. Right. So part of what we do, and this is working with both our subject matter experts and our patient reps and our lived experience reps that we use as well, is really cross-check as much as we can. What are the risks that we could possibly imagine regarding this information? And this would include risks of bias and discrimination and harm.
That's great. Going to jump to, there's a question that came up around the ballot process. So I know that you have a consensus ballot through HL7. Do you have something similar with the different terminologies such as latency and SNOMED?
We do. Yeah. Oh, sorry.
Oh, okay. No, go ahead. Yep. No. I'm trying to read it. Yeah.
So all of our work is consensus based. All of our work is public, right? So the HL7 process is very, very formalized, but within the terminology development work as well, all that kind of the icon line that I represented. So we collectively, as a group, publicly, everyone can submit concepts for consideration. We do that brainstorming bit. We collectively, as a group, do what's called an end-to-end review, which is any person in the collective, any person that's coming on a call can write an email saying a couple different comments on the set as it's in development, which is something's missing, something's wrong, it needs to be changed, or something should just be removed, right? Because it's wrong, or it's too risky, or right. So that whole process is called end-to-end review. And then we have a consensus voting process, which uses really the same HL7 standards votes. And again, so you can say all good, yes, yes with comment, which requires resolution. We just completed our vote for our stress domain, or you can formally say no with an objection. An objection requires a path to remediate your concern, though. So you can't just say no. You have to say no, do this, right?
Yeah, yeah, it's great. Yeah, I was actually on the last call, and so I admired your ability to see the chat and actually present at the same time. So that's quite a skill.
I know, it's like I joke, it's like a Texas cattle auction.
Yeah, it's amazing. So speaking of stress, Annalyn actually has worked in this around stress for her research as well. So her question is this psychological stress or physiological stress? And what was the rationale for conceptualizing it as a social determinant?
Yeah, so this is a very apropos question. So we actually operate now in a contract through Center for Medicaid and Medicare Services. So we're bound to complete the domains as they're represented in this contract. This is about to end and will be a little bit more freeform for a bit. So stress was on the project plan as identified again from that National Academies of Science paper on capturing social and psychological domains in electronic health records. I can actually try to chat that paper into, it's a white paper printed by the National Academy. And so that's why it made it on the timeline. As it is, of course, once you start talking to subject matter experts, all of the sticky wickets of saying that you're going to do something come to bear. So part of what we do when we're identifying a domain is create really logical and what we call like psychometric or measurement guardrails, right? So yes, it is psychological stress, excluding some pretty principal concerns. So if you are a researcher or an expert in stress, we based all of our subject matter experts were the folks within the stress measurement network out of UCSF Siren. So really using their framework for dividing different kinds of stress into different types, basing the psychological stress approach on the perceived stress scale, which is the gold standard screen, making very careful decisions to what we call PARC, right? Right now, we very intentionally decided we did not have the right subject matter experts to address minority stress. And so we took minority stress as a package and said, it's on the timeline over here, because we needed to make sure we had the right group of subject matter experts to do that well. So it's on the timeline, it's on our project plan because of the paper, because of our contract, right? It's defined as it is because of the measurement tools and because the risk associated with specifically that type of stress. And there's things that are not in it because of needing to make sure we have the right team.
Yeah, I think that actually the last meeting I attended, it was really clear that like how you keep moving it forward and to separate these things out instead of, because I can see it would be quite easy to get kind of bogged down in a certain area and the scope really getting too large, right? So
yeah, and we do try to anticipate connections from screening questions and answers to diagnoses, right? So if we're basing our screening question and answer approach and our measurement approach on the perceived stress scale, there's specific answers and outcomes you can imagine just from that tool. Other concepts, other diagnoses might require more refinement, but there are things I can say, right? So that again becomes the kind of like praxis guideline and praxis guardrails. This is what I can say based on these questions.
Yeah, great. Just seeing if there's any other questions, if there's anything. I think that is good.
Wow.
So I do encourage people to go to the Gravity site because it's a bit intimidating, but it's amazing how much is on there. And yeah, I guess I've been thinking about how can we actually use what's there and not duplicate efforts here because make it pull from those resources. So thank you. It's been amazing work. Just wanted to
and thank you for having me. It's really such an honor. And although the website might be intimidating, I hope I'm not.
No,
right?
definitely
so, not. I believe Marcy has my contact information and you can always reach out. It's hard to represent all of the work that we do. It's pretty overwhelming. So just let us know if we can help. And we're really, really grateful for our Canadian colleagues. And thank you for having me.
All right, great. And I want to extend my thanks to our two earlier presenters, so Julie Stratton and Andrew Pinto again, and Mena for being behind the scenes and organizing this day, and also Kai and InfoWay for promoting it, and UVic as well. So thank you, everyone. The videos will be on the UVic site and the InfoWay site. And we'll send out a follow-up so that you can figure out where the link is. So thank you.